the risk groups. But notice, look. 39%, 21 of these people had none of those risk factors. So it's got to be the vaccine plus some of those other things that we have to worry about. When you look at those clotting things, this is through December, the most recent data I could get, right? What they look at is that you're going to have trouble in about half a person per million dosages, right? And so you have to know about that. But I want you to look at something. This is very important. Look. Please look at this, right? Who are the people that had the greatest risk in this group? Look at this. The females in the younger age groups. Okay? The females in the younger age groups had the greatest risk from vaccination. But that's not the group that has the biggest risk from natural infection. So now you start to see why I have certain opinions about whether or not I think it's a good idea to get a booster. I'm not talking about the primary series, but the booster. You can also see why these things work great. I'd rather you have a vaccine than not. But if somebody had never taken the primary series, I'd say probably get an mRNA. Now I'm going to show you the data slightly differently. It's a little confusing, but I think it highlights a point. So stay with me on this. Here we go. On the left side here is all the people that you're benefiting based on age group. On the right side here is all the bad stuff, the clotting, the Guillain-Barré, the myocarditis in these different groups. And they're small numbers, aren't they? Relative to how many people you're helping, correct? Yes. And this is true in females, and this is true in males. But what I want you to know is a couple things. One, this data is most applicable to people from more serious variants. When you start having milder variants like an Omicron, then the amount of people that you're really helping starts to drop. But the risks of the vaccinations, and in particular the booster, go up. And we already saw that some of the most common areas of trouble were in the young age group. But these are the people that are helped the least by getting a booster, right? We know that with the mRNAs, you also get myocarditis, right? We know about some of these other troubles. So that's why I get very careful about what to do with boosters. I'm not talking about the primary series. That is a useful discussion. It is something we could talk about, but I'm really starting to focus now on those boosters, right? Okay, next. I want you to look at this, the kids, right? So this is in the VSafe program, about 7 million dosage administered. Breakdown types of kids, right? Male, female, about equal. Here we go. You look at those dosage administered, and then you start seeing the reports of side effects. And you can see by age, right? So you can see that in some of these young kids, there are reports of side effects. Now, what are those reports? Okay, let's take a look, okay? So you have fever, vomiting, chest pain, some electrical or laboratory changes, but all of a sudden you've got some intensive care attention, you've got seizure, people are starting to have more blood testing done, which means that usually there's more serious stuff. What I care about a lot is the verified reports of myocarditis, which is the inflamed heart, and there were 2 reported deaths in the review. Now, hold on a minute. Hold on. Now you're telling me that in kids age 5 to 11 who have overwhelming data that get very little illness, if at all, from coronavirus, that I'm having equal if not greater risk from the vaccine compared to natural infection. Now, look. You have to understand this very carefully. I'm not saying that they shouldn't get immunized. There could be very good reasons, like breaking down the transmission in a community. So not everybody is sick at once. Well, that certainly helps the hospitals if they're really having a severe outbreak. But in a milder infection, they're not going to overwhelm the hospitals anyways. It certainly can help if those children are interacting with our citizens that are more at risk, the elderly, their grandparents, people with significant medical conditions. Okay, that's fair. But let's be honest about that and not lump them in with everybody else and say, hey, wait a minute, everybody should get these vaccines and everybody should get a booster, right? When you're looking at the reactions, you can see that some of them were more severe than others and meant that we had to really attend to these folks. Not that they shouldn't get primary series, not that they maybe shouldn't get a booster, but you really have to talk about that long and hard to make sure that you know that you're weighing that data back and forth to have a good clarity on how you look at that data. Okay, now, next, the variants. Okay, so this is the classic one that everybody's seen before, the alpha, beta, gamma, delta. There's been mu. Obviously, we're talking about Omicron. And in the original look at the Omicron, when it's first coming out, low levels. And by the way, this has gone all over the place about, you know, how much Omicron is there, but in general, it's clearly dominating the US now. How much does it dominate? Well, that's a very good question because it's very hard to get good data on this. But that has grown to really displace any of the more worrisome things, right? And if you give an mRNA vaccine to the population, you're going to see these kinds of graphs. I know these are a little hard to see, but what they're talking about is that over time, if somebody takes a placebo, which are the blue lines, versus somebody takes the mRNA vaccines, they have very low levels of risk, right? They get very good benefit. Similarly, I know it's getting a little busy, but stay with me, please, please, please. Look at the different variants, alpha, beta, gamma, delta, epsilon, lambda, mu, right? This study was done before they had time to fully look at the Omicron, right? But nonetheless, it gives you an idea of how much variation there is in these antibody neutralization studies and how good they are at going after it. But in general, it works against all the variants. So if you look at some of the typical vaccine variant studies, you're going to see data like this, right? Blue line goes up, placebo, people didn't get it. Red line, the one that got it, big difference in the incidence of infection. So very efficacious, 97%, amazing, right? Why are there some differences, right? Well, one reason is because when you took the vaccine, they make a big difference. It turned out that if you had intervals between the primary series, your first and second shot of the mRNAs, and you increase those intervals, you probably got more protection. So that's why in some places you see different data sets. We're going to be talking a lot about Israel because Israel's been at the forefront of a lot of this stuff, but I want to explain why some things can be different there. But you see these huge efficacy. So you're going to say to me, well, so why are there boosters if they work so well, right? Because if these have such long efficacy, why are there boosters, right? Well, first of all, let me tell you about the benefits of real illness. Here's a group of people. Now look, this is very important, very important. From New England Journal, one of our top journals, right? They looked at people who never had vaccine. They looked at people who had an infection and then got reinfected. And they had some people had severe disease, 4 out of 1,300. Nobody critical, nobody died. This is the benefits of a real infection, right? Now, I'm not saying it's not an easy walk, right? Because look, in some of these primary infections, there was trouble, right? But that's also with different variants. When you start talking about the milder variants, then this data about worrisome primary infection doesn't hold up. And indeed, that's exactly what we're seeing right now with the current variant. So keep that in mind, because we know that the real illness will protect you and probably equal, if not better than the vaccine, okay? Israel. So Israel came out and said, well, hey, wait, we're seeing some data that we're having drop-offs in antibody levels, and we're worried about the breakthrough infection rates, right? And when you looked at some of the data, similar to the Mayo Clinic here, they started to show that Moderna was 76% effective, Pfizer 42%, right? They're saying, wait, hold on. But remember, I already told you that you just have to have 3% of those antibody levels, and you're going to be protected against the more severe stuff. 2, these were done with the Delta variant, right? Not with Omicron, and not with Mu, and not with the other ones that'll be coming. So every time that you hear about these drop-offs, you have to understand, yes, I've already told you there's drop-offs. Yes, there are some people that would benefit from booster if they're particularly vulnerable, right? But for the vast majority of people, that's probably not necessary. Furthermore, when you're talking about it, you have to know what variant you're up against and who's the patient, right? So there are going to always be breakthrough cases. Get ready for it. It's always going to happen. It doesn't matter if you have the real infection. It doesn't matter if you have the vaccines. It doesn't matter if you boost yourself forever. There's going to be some breakthrough infections. But